This discussion is on strengthening India's CKD response. And we will be talking about policies, prevention, and the public health system. And the moderator for this session is Dr. Bhowmik.
Thank you, Marian. I think this morning we've been having wonderful discussions, sessions, and as someone mentioned that, that it was mainly for CKD oriented. I'll change the flavor a little now because I strongly believe that the kidneys are much more than what they're projected to be. Merely, the filtering organs and the waste product removal organs. Kidney is an extremely complicated organ and one of the best, I would say, because, the heart, cardiologists don't like me for saying this, but then I always say that it has only 2 types of cells or maybe 3 types of cells. The kidney has 23 different types of cells organized in a very complicated spatial manner, and that it does amazingly. We have seen here that the 20th World Kidney Day, they have put this logo, and this year is indeed the 20th anniversary of the World Kidney Day. How many of you know here which day is the World Kidney Day? 12th March, that is written there, but that is not the answer. It's the second Thursday of every March of every year. It's a little complicated, but then that's how it is. It is not a fixed day. So this was started 20 years back for dissipating the kidney knowledge, which is very poor amongst all of us. And this logo was the logo of the first World Kidney Day, which said that kidney is an amazing organ and it does so many functions and it filters about 200 liters of blood. So one must know whether your kidneys are okay. So this was the logo of the first World Kidney Day. We've moved on a lot from there. We have had various themes over all the years, and now it is health for all for the last 5 years. And this time the special theme is that protecting the planet along with health for all. So the kidney does 4 very important functions, apart from blood purification, which we're all aware of, where the waste products are thrown out, the fluid balance is maintained, the electrolyte balance is maintained, the acid-base status is maintained. So that is a very function which everyone knows about it. But more importantly, it also does the hemoglobin production, and that's the reason why most of our patients, 80%, 90% of them are anemic. It plays a very important role in the bone health. To keep our bones healthy, merely taking vitamin D is not enough. First, your liver has to activate it, and then the kidney has to activate it. Only then it can protect your bones. And very importantly, it maintains the BP. Heart is a pump. It's only a pump. The BP control rests solely with the kidney. So the kidney plays. So anyone who is a hypertensive, especially if it's young and has anemia, 90% chance that they have kidney disease. That's very important. So knowing these 4 disease conditions are very important. So we've been talking about the chronic kidney diseases, but then the kidney diseases can not only be chronic, but they can also be acute. And the acute ones are the ones which have sudden onset and are potentially recoverable. This is very important because they have to be diagnosed and treated early. And just briefly, there's the UTI, there's the nephritis, which we call, and the nephrotic syndrome, and the acute kidney injury, which is very important from this perspective as well, because AKI, if it is not treated in time, it can either lead to death or it could become CKD. So that's the reason why one must pay great attention to appropriate treatment of acute kidney injury. The chronic kidney diseases would be what is called as the renal and renovascular hypertension, whereby what happens is when the blood supply to the kidney is reduced because of too much lipids in the aorta or some other conditions where the flow is reduced, the arteries become thin, the kidney becomes ischemic, that leads to hypertension. That's one form of chronic kidney disease, which can go into CKD as well. And then, of course, you have CKD, and then there could be various types of obstruction. So this gives a holistic view of all the kidney diseases, and then we know how to go about it. So as Honorable Minister also mentioned that, urine examination plays a very important role in detecting kidney disease early. And it's very important that one performs the test not only in the lab, but also bedside or in the ward. So that's what I strictly follow. As you can see that date there, I think 2013. So, I mean, we have these multi-sticks whereby you can pick up 10 parameters and the kidney health can be reasonably detected in the ward or in the OPD itself. We send the urine to the lab as well, where it's examined in the microscope for the sediments, the RBCs, WBC, CAS, and the protein examination, which is more accurate, more correct by the 24-hour test, or now very simple, a single urine at any time of the day called as the protein creatinine ratio, there at the right side. We check the blood for the urea, creatinine, the GFR, as well as the other electrolytes, etc. Investigations play a very important role. So the ultrasound scan picks up the kidney size, its structure, its ecogenicity, and the nuclear scan is more accurate in telling us the differential function apart from the overall function. So this is a beautiful image of both the kidneys functioning very well and the bladder also getting filled with the urine. So coming to the common diseases, you have the urinary tract infection. I'll not go into the detail, but then this must be treated early. You have the nephritis, you have the nephrotic syndrome, where the child or the young man or woman suddenly gets bloated up. And the definition is very important that if anyone has any renal problem for more than 3 months, as a rule of the thumb, that becomes CKD, either by blood test, urine test, or by lab test. That is CKD. As was mentioned that CKD has stages, and unfortunately the silent killer. Why? Because these 1, 2, and 3 are at the bottom of the iceberg, which you don't see. So 1, 2, and 3 are unseen. What becomes visible is finally only the tip of the iceberg when it is already 4 and then ultimately 5. So the whole aim should be in picking up the disease when it is in the early stages, 1, 2, and 3. Honorable Minister mentioned about diabetes, hypertension, but it's good to remember that the other important causes as well, like the glomerulonephritis, the kidney is basically 3 compartments, the filters, the tubes, and the blood supply. So anything affecting, and the outflow tract, anything affecting any of them could cause kidney disease. Now, after going through all these conditions, still about 15 to 20% cases, one cannot diagnose what is the kidney disease. And then we say it's unexplained or unknown. But then before calling something as unknown, one should take all the measures to eliminate or find out the cause of CKD, because that has a bearing on the management of the patient as well as the post-transplant care. So it's very important that one tries to understand the cause of the kidney disease. Right, so I mean, there's some cases where kidney disease occurs, because there's reflux when the urine flows backwards, or is a cystic disease where the kidneys are filled with cysts, which is actually a genetic condition. Thank you very much. So now, having given this background, so where you can understand kidney disease better, I'll now call upon my very distinguished panelists for the panel discussion. May I have the chairs, please? I'll call them. These are Tushar. Right. So I first call upon Professor Vivekanand, a close friend of mine. You already know him very well. He has moderated the first panel discussion this morning and has been very active in the various discussions subsequently. So he needs no further introduction. And it's a pleasure to invite Dr. Vivekanand to give his thoughtful insights for the program. Dr. Tushar Nale, I hope is here. Yes. Welcome, sir. We are really lucky to have Dr. Tushar with us this morning, who is the Assistant Director General in the Director General of Health Services under the Ministry of Health in New Delhi. You can come closer. I understand he is a graduate and a postgraduate from Topiwala National Medical College, Mumbai. Is that right? Yes. And I'm also from Maharashtra, so it's nice meeting you, Doctor. We have spoken on phone a couple of times. I have not met him earlier. He is a public health specialist and is a medical consultant who has worked as a consultant to the RNTCP as well, the tuberculosis. He has been deputy director at the NCDS, National Center for Disease Control. He's a senior member of the Center for One Health India. Madam mentioned about the One Health initiative of the government of India, for which there's a panel of doctors, and Dr. Tushar is one of the senior members in this panel. And also very interestingly, he has several publications. In spite of his very busy administrative schedule, he has a very good academic record. He has published several papers in reputed journals. So welcome, sir, and I think you'll be able to explain various government policies and initiatives in this regard. I also invited Arun Gupta. He's here. Yes, yes, Dr. Arun. So he is basically a pediatrician, and it's nice to have a pediatrician amongst us, who after 11 years of practice in Jalandhar, Punjab, gave it up in the early 1990s to promote and protect breastfeeding. He became a fellow of the Indian Academy of Pediatricians in 1991. And for the last 35 years, he has played a very key role in strengthening the national policies to promote, protect, and support breastfeeding, which has made a significant impact in promoting breastfeeding as well as food and other nutrition policies. So welcome, sir, and I'm sure and he's coordinated with the government officials and NGOs for a better, healthier lifestyle as well. And lastly, it's my real pleasure to invite Dr. Shantanu Saha. Yes, he's Mr. Shantanu. Yes, Mr. Shantanu. He's a patient representative. Wonderful life, I would say, who being HR manager has gone through a lot. He has the cystic disease, which I showed you, which is a genetic disease, which he inherited from his father, and in which the kidneys grow very big and ultimately leads to renal failure. So, I mean, it's very important that you diagnose it early. Now there are very many genetic tests as well. So he ultimately had to undergo removal of the big kidneys, because when the kidneys become too big, they cause pain, there's bleeding or there's stone formation. There's even no space for putting in a graft transplant. So, I mean, he underwent a nephrectomy, bilateral nephrectomy. He had a transplant, then even that graft had to be removed. He has a second graft now, and very happy to say, he's leading a very healthy and useful life to society. So, we have these distinguished members with us this morning to deliberate on how we can strengthen India's response to this surging epidemic of chronic kidney disease. So we'll talk about the various government policies with regard to screening and how we can make the screening better, what we can do regarding the various schemes and food labeling and education. So I'll first just take up this question of screening, which I'll address to my venerable members. So Vivekanand has done a lot of work on this, he's published in this and very well qualified. We have seen the causes of chronic kidney disease and how we can prevent them. So screening obviously plays a very important role. So your thoughts, Vivek?
Thanks, Dr. Bhowmik. So yes, we come down right to the business, and you use the word screening. I'd like to make a bit of distinction here. When we say screening, typically in medical parlance, it means that you are talking about testing the entire population. I would suggest that we move away from using the word screening to early detection, disease detection, right? So that's an important one. Why it is important is that whenever we propose an approach, it needs to be the one that provides the most value for money. When policymakers decide to make an investment on something, they also want to know what is going to come back in return for that investment. So now we have evidence from multiple studies around the world that a population level screening approach is not cost effective, because the prevalence of kidney disease, especially progressive kidney disease, is about 5 to 6%. If non-progressive kidney disease included, it will go higher, 10 to 12, etc. Right? So it's important that we, as physicians, pediatricians, and other members involved in the healthcare community, first recognize and identify who are the people who are at increased risk of developing kidney disease. And Dr. Bhowmik did an excellent job of showing a list of conditions which increase the risk of development of kidney disease. So we should take all possible opportunities to make sure that those individuals have access to testing, right? So testing for early detection of the disease. And what are those tests? These are very simple tests. One is a serum creatinine test, which allows us to measure the proportion of the filtration function of the kidney. Serum creatinine can be used very easily to convert that into a formula, using a formula to what we call glomerular filtration rate, which tells us how well the kidneys are filtering our blood. Second, which is more important, and I think that is a message that needs to go deeper into even the professional community, is the testing for protein in the urine. And the right way of testing for protein in the urine is to look for what is called albuminuria, the albumin test. So there are a number of tests which are available, but testing for albumin is the most sensitive, and we can follow that to see whether it is going up or down when we start treatment. So these two tests should be included in any package of chronic disease care. So whenever we come across anyone with diabetes, anyone with hypertension, even at first encounter with healthcare system, we see as nephrologists and others also, people with hypertension who were diagnosed many years ago, 5-10 years ago, but their kidney function was never tested, right? So that is something we should do. We should make sure that using any opportunity, so this is called opportunistic screening or opportunistic case detection. Whenever they come to a health encounter, they get tested for this. And hopefully, in an ideal world, we will get to a scenario where through the Arogya Mandirs that the minister spoke about, or other peripheral facilities, we will be able to offer testing for serum creatinine and urine albumin to all the individuals who can benefit from it. Some other conditions that Dr. Bhowmik's list did not include, but they are emerging conditions now. One is obesity. So obesity is also a risk factor for kidney disease, and one is that we should prevent obesity, irrespective of whether one gets kidney disease or not. But all obese people, especially obese children, should be tested. So that's number one. Number two is anyone with a family history of kidney disease, and Shantanu's story tells us that any kind of kidney disease, if any patient has in their family, they should be tested. Their kidney function should be tested. The third now, which is increasingly becoming common unfortunately, is the environmental change related health risk factors like air pollution. Air pollution has been identified to be a risk factor for kidney disease. So obviously it is not possible to test everyone living in Delhi because we are all exposed to bad air here in Delhi, but exposure to extreme heat, really bad air pollution, etc. So I think we will slowly need to expand the list of conditions which cause us to test people for the presence of kidney disease. Now, ultimately, I'll say just one thing and then stop, is that as the community, we need to develop health economic evidence to help our policymakers, because we have to say that, look, if you spend 10 rupees, ultimately the society, not in terms of only spending directly on healthcare, the society will save 15 rupees, 20 rupees, and that saving can be in the form of savings for more advanced type of care that the patient might have needed later on, like dialysis. So if they don't need dialysis, we can save money. But also they can become more economically productive. They can contribute to the society. They can contribute to the GDP of the country. And that is also, that also comes into this cost benefit accounting. And so we have to make, as as the nephrologist, that's our responsibility as nephrologists to make that kind of economic case.
Thank you. I think you brought out the points very well. I'll just reiterate again what Dr. Saha mentioned, that day in, day out in our OPDs, we routinely see long-standing patients of diabetic hypertension, such fat files, having so many investigations, the urine would not have been done. So, I mean, this shouldn't happen. Urine must be examined. Worse, even yesterday I've seen, urine has been done, but that has not been done properly, and they've missed albuminuria. So I think it's very important that these tests are done in all these high-risk groups, as he rightly brought out, and it is done correctly. As a pediatrician, Doctor, do you have any further insights and thoughts into screening the children? Anything that you would like to add to this as a pediatrician?
I'm sorry, I'm out of touch of clinical
Okay,
science.
no, man, yeah, that's
94,
fine.
So I'm not seeing any patients at the moment since 94, so I won't be able to answer this.
Right. So, but basically, children have a little different group of diseases than what I've shown here, apart from obesity, which is there in children as well, is that they have one of these congenital abnormalities. So the Kakut is a very important thing.
So just on that, so if I can add, Dr. Bhowmik, on children. So I think we have a unique opportunity. Pediatricians have a unique opportunity to identify and prevent kidney disease even earlier. Why it is more important to do so in children is because they have a greater lifetime burden, right? Because they are very young compared to adults. Adults may develop kidney disease in their 40s, 50s, 60s. But children will develop kidney disease very early, and so their burden will be that much greater, disproportionately higher healthcare expense, etc. So the prevention could be, for example, antenatal screening. Now we can do antenatal screening and look for any anomalies in the genitourinary tract through ultrasound. Ultrasounds have become very sensitive, and doing the appropriate type of test right in the beginning. Dr. Bhowmik talked about reflux. Reflux can be picked. It was not very uncommon when I was a trainee, and I'm pretty sure even now, that the reflux disease, in which urine, instead of coming down from the urinary bladder out through the urethra, goes back up the ureter and affects the kidney, that this was missed for years together, and then people used to be picked up very late. Now with tests, it can be picked up early. I'm sure pediatricians are doing these kind of screenings and picking up. In some countries like Japan, Korea, etc., there are school screening programs. And so simple urine test is done, just urine test at the time of school enrollment and periodically. And they're picking up a large number of people with children with albuminuria or hematuria, in which you see red blood cells in the urine, and thereby prevent kidney disease progression.
Thank you. Dr. Tushar, perspective from your side, from public health side, if you'd like to add to what has been mentioned.
I would like to mention the few of the schemes under the various program at Government of India. So Honorable Minister mentioned few of the things in her speech also. I'll just elaborate. So one of the point was, sir, also mentioned that early detection is rather than the screening. We have this national program for prevention and control of non-communicable disease, and under that we undertake this population-based screening for the common diseases like hypertension, diabetes, and 3 common cancer, that is oral, cervical, and the breast cancer. So for this hypertension and diabetes, all the 30+ individuals are universally screened, and over the period in last almost 5 to 6 years, more than 40 crores has been screened and for hypertension and diabetes. And at the same time, those who are diagnosed, we have the continuum of the care, diagnosing, screening by the community health worker or at the AIIMS Arogya Mandir. They were referred back to the medical officer for the proper diagnosis and then putting on the treatment. But then beyond that also, we try to keep the continuum of treatment, keeping the regular follow-ups and monitor the control. As diabetes and hypertension are the one of the few risk factors identified for these chronic kidney diseases, we also try to have this, as sir mentioned, the identifying the urine microalbuminuria. So for that, at the more than 180,000 AIIMS Arogya Mandirs are there, and in that this test can be performed. The access to the serum creatinine, so testing serum creatinine at PHC and above health facility, at least for the block level health facility CHC, they are there, and in our guidelines or the norms, PSCs also should have this test for the serum creatinine. It was not that all the PSCs right now will be having that facility, but then it is a vision documents, and over the period that can be very well we can connect or improve the access with respect to the screening and the early diagnosis by the government.
Yeah, thank you. So I think it's very important that once they are screened and picked up at the Arogya Mandirs or the BHCs, they are followed up subsequently, and you have this good opportunity to refer them to the higher centers. So they are picked up early. Yes, Shantanu, your perspective from screening, because I think you are very well versed with kidney disease and you have your patient perspective as not only for other diseases, for other genetic diseases as well, through which you have gone through.
Yes, Dr. Bhowmik. In fact, in my case, if I talk about, I had hypertension as a kid probably also, but didn't take it seriously at that time. Later, when I in fact look back at the past records, I saw, it was consistently high. When my father passed away from kidney failure, we were not aware that ADPKD was there, but I got diagnosed early because we had a corporate, when I was working in a company, we had a routine corporate testing, full body checkup, and that's when I got to know that I had ADPKD. And of course, that time doctors were, there was not very good prognosis, and they were like, pretty much this is 50% chance of survival kind of a thing, and there is no cure. So multiple things. One is, of course, screening. But Dr. Jha said that, screening the whole population is not a sensible thing at this point of time. But anybody who's in the high risk category, either because of genetics, if they have somebody in the family who's had that history or, has this thing, they should definitely get screened. If they are hypertensive or diabetic, these two are extremely high risk groups. And I believe in any dialysis ward, around 80% of the patients would be, who are in CKD patients are the ones who are on dialysis are because of hypertension and diabetes. Apart from that, another thing which I want to point out is, and this is from the government's point of view, is this disease, one, without a cure, second, extremely expensive for people. So a lot of people in our country definitely cannot afford to sustain themselves. So for example, the cost of dialysis in any decent hospital, even if you do, the bare, what WHO standards and whatever the standards are 3 times a week, it is 60,000 rupees per month just for dialysis. Apart from that, the doctor consultations, medicine costs, all that, which is out of reach. So that is where the government, see, I can understand that this is not available in terms of, you don't have the infrastructure. AIIMS itself is overburdened, for example, in terms of probably not that many people they would be on the wait list for dialysis, right? So probably some kind of financial assistance for majority of the people, anybody who's on dialysis, so that they can go get it done wherever it is possible. Of course, today we also have a digression between tier 1 and tier 2 cities in terms of availability and quality of dialysis that's happening. That's another thing I would want to, sort of highlight.
Thank you. So I think we have discussed various aspects of screening. I'll just add a couple of points here. I really admire Vasundhara Madam for doing the screening, the cab drivers. And this is done routinely in the Southeast, in Hong Kong, Taiwan, and they have picked up a lot of kidney diseases. In fact, in Taiwan has the highest rate of kidney disease, which I feel not because the people there are sicker, but because they are picked up early. So it's important that that is another group which can be picked up. The school children has been mentioned. I'll just mention one more thing here, which I quite close to my heart, is screening appropriately the ANC, the antenatal checkup, the pregnant women. This has importance from 2 angles. One is that you know their baseline function of creatinine at the maybe 15th, 16th week. And then if they develop preeclampsia, you know what is their baseline creatinine and you can pick it up early. That's number one. And then, of course, as I said, it can go on to CKD, so they can be screened subsequently. So any patient, any person who has a medical contact, they should have these screenings done. And pregnancy, I think, is a very important thing. At present, tests are done for other things, but I think one must, specifically from, as Dr. Jha mentioned, for the urine albumin as well as the creatinine. So I think we'll stop the discussion on screening right now. So coming to the second aspect, the government policies can help us, is the treatment part. And that I think is the Pradhan Mantri, once you have the disease and you're on dialysis, this has been mentioned by the Honorable Minister as well. But yes, Dr. Tushar, if you can enlighten us a little in more detail about the Pradhan Mantri National Dialysis Program. I've also been a part of it and the quality management, etc.
So, Honorable Minister mentioned in the morning also, but it's Pradhan Mantri National Dialysis Program, that is PMNDP. So it is being implemented in 751 districts covered. Currently, it is being implemented in the district hospital, but then at the same time, efforts are being done, or thought process or the policy level decision. It can be, if it is possible, that can be wherever possible at the block level, at least few beds that can be made available for the dialysis at the block level, so that more and more patients can get access. Around 1,762 dialysis centers are functional. 12,702 hemodialysis machines are operational. Cumulatively, around 30.45 lakh individuals or patients has been benefited, and so far 396.85 lakhs dialysis session conducted till December 2025. Again, there was some earlier there was one panel discussion where we discussed about the hemodialysis and peritoneal dialysis. So this PMNDP currently on the what I mentioned was about the hemodialysis, but then for peritoneal dialysis also we are around being implemented in 12 states. So far around 2,000 patients has been registered. 14,000 one-time equipment support is being provided for the patient, and the 18,000 to around 27,000 monthly consumable supported is being provided through this National Health Mission program implementation of the states. But it is not the 100% is not being through the union government. It is 60-40 or
Right.
90-10. The state has to take the initiative. At the end of the day, health is being a state subject. It is the state health department that is more which is the implementing agencies, and that demand generation should be at the state level, so that can be schemes at the at the national level that can be implemented at the
Yes, I think that's a very important point, that the health is a state subject as per our constitution. So the state government plays a very important role. In fact, some state governments have taken a very proactive role in management of kidney diseases, like the southern states. So where in the dialysis, especially in Andhra and Telangana, even before this PMNDP, they have been giving free dialysis to their patients. Now, since we have the patient population here, so apart from the government agencies, it's also pertinent to mention that there are many philanthropic societies which also give very good free dialysis to all our patients. So it's good to know about the various things, which could be various religious bodies or other philanthropic bodies. So in our institute also, we always maintain a list of all the centers in the city which provide dialysis, because dialysis is a life-saving thing, and we now have this good opportunity to refer our patients to any of these centers. Any of the other panelists would like to make any other comment? Yes, Dr. Jha.
Yeah, wait to hear from Dr. Gupta, but look, I want to make a couple of points. One is about dialysis. So we often spend disproportionate amount of time in talking about dialysis. Of course, dialysis is important, right? And hemodialysis is the one that has taken up in the PMNDP program and subsequently in NHM. But I would really strongly advocate for all of us to think about promoting home-based dialysis programs as much as possible. Because you said about providing financial assistance, etc. There is no end to providing financial assistance. And because that is the out-of-pocket expenditure for in-center dialysis is continuing to go up. In terms of travel time, in terms of caregiver expenses, and so on and so forth. And all of that can be substantially avoided by promoting home-based dialysis, peritoneal dialysis. So I was involved in putting together the guidelines for development of peritoneal dialysis program for NHM. So that was a very rewarding exercise, and it's really great that it's now being implemented, but we need to do much more about it, about promoting home-based dialysis. And that is where we need patient voices to speak up and say that, yes, we need more of it. Because there can never be enough number of dialysis machines to give dialysis to all the patients in our country. It's a huge country, with a very large number of people who need dialysis, but can't get it. So that's one. The second thing I would like to say is that as you said now, and we have said, that now there are a number of very effective drugs that can prevent the progression of kidney disease and development of complications. We have, for last 25 years, we had just one drug, one class of drugs called as angiotensin receptor converting enzyme inhibitor class of drugs. But now we have SGLT2 inhibitors, we have mineralocorticoid receptor antagonists, we have now GLP-1 receptor agonists, we have now possibly aldosterone synthase inhibitors coming in, etc. And all of our patients do deserve to get the benefit of all of those therapies. So we should, again, as a patient body, you should advocate for making sure that those drugs are included in the list of essential medicines. I'm not sure if you're aware of this or not, but inclusion in the list of essential medicines is the first step that is required to ensure that yes, those drugs will be available in PHCs, CHCs, etc. Obviously, those who are lucky enough to have insurance, they can get reimbursement through insurance. But a large proportion of our fellow citizens don't have that luxury. They don't have government insurance or private insurance. They will need to come and get their treatment through the Arogya Mandirs and through other similar schemes. Unfortunately, the PMJY scheme or doesn't cover OPD treatment coverage, right? So they won't. So it is not like they can go and buy it from the market and get reimbursed. That will not happen. So they will have to get the treatment through Arogya Mandirs. They'll have to come and collect the drugs. And unless they are there in the list of essential medicines, that won't happen. So my plea to Kidney Warriors Foundation is for us to work on that and get that to happen. So these are the two main things I would say. There are effective drugs. Let's recognize those effective drugs and focus on those rather than drugs which are not effective and they have somehow the word nephro in their names and patients think that they are some kidney magic drugs.
Yeah, that's terrible actually. I mean, there are some drugs by the name of Renosave, Nephro, they have this and they mislead the public and one has to be very careful. Yes, to continue the discussion on Ayushman Bharat and the PMJY schemes, Dr. Tushar, your inputs. And the problems that we are facing, one of the problems has been mentioned that OPD treatment is not covered at the moment. So how we can improve it further?
Right now, for this PMJ, 5 lakhs per family per year coverage is there, under which dialysis, peritoneal dialysis, kidney transplant and post-transplant care has been supported. But then I understand that 5 lakh is not the adequate amount for the kidney patient. And this is not only for the kidney diseases. 2 days back we had also another meeting with respect to cancer, and for that also this 5 lakhs, this has been highlighted during discussion that the 5 lakhs is not enough per year, enough money or amount that will help this such kind of chronic diseases. So these higher authorities has been sensitized that over the period NHA, the National Health Authorities, will discuss on that and may try to, because this demand has been generated that this is not the enough funds for the covering. So that, but then in government things take time to convert. But then this issue has been identified. The first step is the acceptance.
Thank you. So I hope soon this will be rectified and patients will have better coverage. Now,
so
come to a
I just add to there are two more schemes which are very little been utilized or less popular. This Rashtriya Arogya Nidhi, up to 15 lakhs that has been can be provided to the patient, and this is specifically through the government hospital. There are few empaneled government hospital which includes all the AIIMS and key major medical colleges, government medical college. So that can be utilized. This is very been not being utilized, like very limited expenditure has been observed in this such a kind of this Rashtriya Arogya Nidhi scheme. And there is another, this health minister discretionary grant. So it is not much popular and very limited fund runs there, but then 1.20 lakhs can be given to the kidney patients also. So these are additional two schemes.
Yes, thank you. We also have the PM fund and the CM fund, and so people get money from there as well. So at AIIMS, we always encourage that they get from those parts. Now, moving on, our patients also, the food is a big problem, and what to eat, what not to eat. And often people buy the packaged food. And so it's very important that, they are well informed, as was discussed earlier. So we have amongst us who has done a lot of work on this. So Dr. Arun, will you kindly enlighten us on this problem and your solution and your inputs?
Thank you so much for having me. Thank you, Vasundhara ji, and thank you, Kidney Warrior Foundation, for organizing this wonderful meeting. I like to add an emphasis on the prevention. Most of the speakers since morning have talked about prevention. So I'm adding a word to it, primary prevention. So the reason is that in the recent national surveys, we found that 1 in 4, about 20 men and women have obesity, and 1 in 4 above 20 have diabetes or pre-diabetes. 1 in 3 have hypertension. 10% of 5 to 19-year-old children have pre-diabetes. Obesity has doubled from NFHS 3 to NFHS 5. Same in children. It has almost doubled. It's still not that, in the figures like about adults, it's about 24%. In children, it's about 4%. Under 5 years. So this is an area which I think should cut across all specialties, including nephrology, and also the whole medical science. In terms of when we talk about prevention, how do we actually prevent the whole disease pattern emerging in our families? As the minister also said, other people also were commenting that, every family you meet, you find a diabetic person. So this is an important area which we have been seeing last 10 to 15 years, this new generation of fake foods, these industrial food products, don't call them even foods, which have been developed in a way they are engineered to be addictive, which carry high level of salt, sugar, fats, other colors, flavors, emulsifiers, God name them. If you can pick up a product in a pre-packaged liquid or solid, I'll give you a few examples for you to mulling your head on, because we have been consuming almost on every day. For example, biscuits, chips, then noodles. These are becoming more popular. And then we have in the drinks like so-called fruit drinks. They are nothing like a fruit, but all the sugar and the colors stacked in those bottles. And then obviously the cola drink, everybody is now getting aware of the sugar part. So the point is here that we have to start identifying at the family level. So I'm a bit disagreeing with the government on calling it eat right, because it ends up blaming people that you don't eat right? But we don't check the environment. So I would encourage the government to use the word real. So rather than campaign eat right, which blames the people, so say eat real food. So real food means minimally processed. We have been processing food for ages, millions of years, but this industrial processing is costing our lives. Incidentally, the new terminology is called ultra processed foods, which we have been hearing since 2009. Brazilian nutritionist defined a definition of food by its processing, by intent and purpose of processing. So they term these fake foods as ultra processed foods, which contain these ingredients which we don't use in normal kitchen. So we don't use emulsifiers in the kitchen, for example. We don't use stabilizers. We don't use artificial colors or artificial flavors in our kitchens. So they were all made to actually, what I said in the beginning, they are addicting products. They are now being compared to tobacco. There are cases have been filed in US in terms of, one is the San Francisco government has filed a case on 10 companies, and now day before yesterday, a mother has filed a case because their children, 9-year-old boy who got type 2 diabetes, and she related it to drinking too much of these ultra processed and eating too much of ultra processed because of the game behind is marketing. So that's where I'm coming to my point on policy. The primary prevention can help only at the policy level, where it covers all the population, where the preventive regulations we learned from our experience during baby food battles in early 80s and 90s. So baby food marketing led to dismantling breastfeeding in the country. And now that's the reason I stopped working in pediatrics, in clinical pediatrics, and jumped onto the public health side since 90. And we got a law that bans the promotion of baby food. We don't see an advertisement of a Cerelac or a Lactogen on the television now, which was supplied free in 80s when I was working in a private practice in Jalandhar. And I saw 17 maternity hospitals all getting free supplies from Nestle, and all mothers were hooked onto bottle feeding. So this is a similar thing happening now in the older children, adolescent, and now in adults. So this is where the primary prevention comes into force. So I would urge that the government is now considering putting a warning label on pre-packaged food products which are high in fat, sugar and salt. So the case has been, the Supreme Court has urged the government to put a warning label. I would ask people who can write to the Minister of Health who came today, just send a mail or a message or a card, or to Mr. Nadda to say adopt warning labels on such products which contain high level of sugar as well as and their advertisements.
Thank you. Thank you so much for highlighting that problem. And I think trans fats are a very huge problem with these ultra processed food, and one must take great care that these are labeled how much trans fats are there in each food, because that is what is very dangerous. And now coming to Mr. Shantanu, from your perspective, what are the biggest misconceptions or awareness gaps about kidney disease amongst the public? Which policy?
So
address?
one thing which I want to highlight is, this whole thing of alternate medicines, a lot of advertisements come in the social media, and that, in fact, earlier it used to come on television also, that they can cure. And I have suffered from that using Ayurvedic, which immediately caused kidney failure. And that CKD thing which could have been stretched for a few years is caused. So government needs to immediately stop, because right now that control is less. So the moment it is highlighted, the government needs to immediately sort of pull up, take action against those, I believe that Magic Remedies Act or what is there. So that is one thing. Second, this front of the pack labeling, where we have worked with Dr. Arun Gupta earlier also, that whole thing of as a patient, when we go to the market, we are not aware what is high. We don't go through the entire list of content. What is high on salt, sugar and fats, that has to be prominently displayed. And that is something which FSSAI for a long time was, a little reluctant. Now the Supreme Court has put it, because Dr. Gupta has been fighting for it for a very long time. And I believe that if it happens, it will help.
Thank you. We'll just have one comment from Sanjeev, because he had raised his hand. Normally you don't have scope for discussions, but then just one short comment, Sanjeev.
This was since Dr. Tushar is also here, and school health screening. So school children, the advantage is a captive population. And as was highlighted, experience from other countries, you just need to have two, one at school entry, that is at 5 years of age, and another at school exit. And a simple urine sticks, urine dipsticks, if we can make it mandatory, it will help in screening out a lot of kidney diseases in children, because these are the patients that we have to target. And there's a lot of scope for prevention also there, and curative medicine.
Yeah, your point is very well taken. Thank you, Sanjeev. Any final comments from any of the panelists before we wind up? Because time is up. Any final pressing comment, very short?
Avoid plastics is another thing I would like to add.
Okay. Yes, Dr. Tushar, you want to say something?
Just to add up, like even earlier, few of the eminent panelists has mentioned, prevention, primary prevention is a key to think, key for prevention, because we have around 1.150 crore population, and even whatever infrastructure we will build, that will not be enough for the treatment. So prevention is the best way, and it should be hand in hand. It is not the only health ministry that can do that. Everyone should join hands, do their part to spread the message of this primary prevention. That's what
Thank you very much. So I thank all the distinguished panelists for their enlightened discussion, and I think all of us have found it very useful. I thank Vasundhara ji and the Kidney Warriors Foundation for giving us this platform. Thank you very much.
Thank you very much, Dr. Bhowmik. And I'd like to hand over a memento to our panelist. To begin with, Dr. Tushar. Dr. Arun Gupta. Thank you, doctors. Thank you, Shantanu.